Welcome back to Ocular Pathology for Falcon Physician Reviews. We left off with the uveal tract. Now we're going to talk about the lens. You can see on this slide the normal anatomy of the lens is that it's a globular-shaped structure in the middle of the eye. It's suspended by suspensory ligaments that are attached to the ciliary body. In front of it is the iris and the pupil, and so most of the time you'll never get a full view of the lens, even in a fully dilated pupil. The normal histology is shown on the left, and a diagram is shown on the right of the relationships it has to other normal tissues. Let's talk about a case presentation to talk about the pathology and histology of the lens. A 75-year-old person presents with decreased vision and difficulty seeing due to glare from headlights at night. We have a picture here, and most people would agree that that's not a normal-looking eye. The problem is not in the conjunctiva. That looks white. The iris and the uveal tract look okay. There's no accumulation of fluid or cells in the anterior chamber, and the cornea looks pretty clear. The problem is the lens. That's a dilated eye, and it has a thick, opacified lens in the middle. That's what we call a cataract. The differential diagnosis for decreased vision in the elderly includes, in addition to cataracts, macular degeneration. This often presents with people with central vision problems but normal peripheral vision. Cataracts usually have a gradual onset of a generally decreased vision, especially if they get complaints of glare. Refractive errors also can be gradual in onset and have other difficulties with near or distance vision, and often it's correctable with glasses. In addition, when you look at the lens, it won't have a cataract in it. The etiology of cataracts they're most commonly due to the natural aging process of the lens. Other etiologies include trauma, steroid administration, or irradiation. The natural etiology of the lens is that the fibers in the center of the lens are the oldest, and they're there in our neonatal life. As we grow, each layer of cells around the lens makes it thicker and more compact. So like the rings on a tree, as we get older, there's more and more layers inside the lens, which predisposes you to get cataracts as a natural event of aging. The pathogenesis, as I said, is the natural age-related accumulation of insoluble lens proteins as more and more layers accumulate. The clinical pathology is degeneration of lens proteins and structures. Signs and symptoms include decreased vision, difficulty with glare. There's also lens opacity is found on exam when you look at it. The basic diagnosis is based on physical exam. Treatment includes surgical extraction, which is the replacement of the natural lens with a synthetic lens calculated to give people better vision. Cataract surgery is one of the most frequently and successful performed surgeries in the world, and it's a great advancement in our surgical technique. Here's some pictures for your information. On the left is an image of the 16th century cataract removal, where they have the instrument noted just right next to it, which looks like a long, sharp stick. Basically, the doctor, quote-unquote doctor, would jab the eye with this long stick, impale the lens, and pull it out. They, of course, didn't have the synthetic materials that we do today to replace it with a synthetic lens, and so you had the poor, unfocused vision of somebody without a natural lens to focus the light on their eyes. But they didn't have cataracts, and so that was probably okay. On the right, we have a gross histology of the globe with a cataractous lens inside. This is a rear view looking from behind of the cataract. You see how it's opacified and will block the entrance of light through the pupil. Next, we move on to retina. This slide is to highlight the functional and normal neural anatomy of the retina. It's a neural tunic, which means it has many different neural layers, and it collects the light as it goes through the pupil, hits the retina, transmits the light as electricity to the brain, which interprets it as vision. You probably memorized the layers of the retina in your preclinical years. It's not bad to know what they are, although you might not be asked specifically what it is. It'd be good to know. You have the nerve fiber layer on the top, most closely related to the inside of the back cavity of the eye, which is the vitreous, the posterior segment. Next to that, you have the ganglion cell layer. Beneath that, you have the inner plexiform layer and the inner nuclear layer. After that, you have the outer plexiform and outer nuclear layers, and then you get rods and cones, and those connect with the retinal pigment epithelium. Underneath that is the choroid, which is the uveal tract, which we discussed previously. You can tell from this slide that the choroid has many blood vessels and is richly vascularized tissue. The choroid provides most of the blood supply for the outer retina, whereas the inner retina gets its blood supply from the central retinal artery. We'll talk about that clinical significance next. Case presentation number 5. A 3-month-old little girl with an asymmetric red reflex on her photographs presents to your clinic. Looking at this picture, you can tell there's a marked difference between the right and the left eye. The left eye doesn't have the normal red reflex, it has a white reflex. That's often called leukocoria. The differential diagnosis for leukocoria, or a white pupil, includes problems with the lens. You can imagine that if you had a congenital or acquired cataract, you would have difficulty getting a good reflex of light from the retina. So that would cause a decreased red reflex or a white reflex. Also, you can have retinal problems. If you have tumor inside your retina, or infection, or retinopathy of prematurity, that'll cause anything that causes the light to not reflect off a nice, smooth retinal surface will change the red reflex. Retinopathy of prematurity is often diagnosed in very premature infants while they're still in the neonatal ICU. If you have someone present to you with leukocoria, ask about a history of prematurity to see if they have a history of retinopathy of prematurity, because that would describe it. Retinoblastoma is a tumor of the retinal cells. The etiology and risk factors are that it's 1/3 hereditary and 2/3 spontaneous. Pathogenesis is that it's a defect of the tumor suppressor gene, which is retinoblastoma gene, and it leads to the abnormal proliferation of neural tissue. You may remember the biochemistry of the retinoblastoma gene and its interactions with E6 and E7 from your preclinical years. This tumor can be locally aggressive and often invades the CNS through the optic nerve. Gross sections of the eyes with retinoblastomas show that this is a big, nasty tumor. It's often fatal for children after it spreads into the central nervous system. Can you see how this would change the appearance of a red reflex through a pupil? This large tumor on the left takes up almost the entire posterior segment. This other tumor on the right certainly would change the red reflex appearance. Histologically, retinoblastoma has characteristic signs which show that it has neural-derived tissue as its origin. The Flexner-Wintersteiner rosettes are characteristic of the neural tissue found in retinoblastoma. Homer-right pseudo-rosettes are tumor cells clustering around the vessel, are found in other neurologic tumors such as Ewing-blastoma, or medulloblastoma, or neuroblastoma. On the bottom left, you have a section of an optic nerve that has evidence of retinoblastoma invading through the optic nerve. This portends a poor prognosis for the child because the tumor has invaded into the central nervous system, is often disseminated, and there's poor prognosis after that. The clinical pathology, as we discussed, has Flexner-Wintersteiner bodies, which is pathognomonic, or the sine qua non of retinoblastoma. Homer-right pseudo-rosettes are suggestive and often present in retinoblastoma, but maybe in other tumors as well. Signs and symptoms include decreased vision and abnormal red reflex. That's why primary care doctors are often taught to learn to recognize the red reflex, and every good doctor should. Basic diagnosis includes a physical exam, also imaging to evaluate the size and extent and involvement of the other eye and CNS versus local or distant spread of the tumor. The treatment is often to remove the eye. If thine eye offend thee, thou shalt cut it out, is the saying. So if you have tumor inside the eye, you need to cut it out before it spreads through the optic nerve to the central nervous system. In addition, frequently children get radiation and chemotherapy. Case number 6. A 45-year-old poorly controlled diabetic with sudden loss of vision in both eyes for the past 3 weeks presents to your clinic. This is a poor picture, but it's the best one I could find to show a vitreous hemorrhage. This picture is a close-up view of the iris inferiorly and showing a dark red coming from the vitreous. That's what happens when there's blood inside the posterior segment of the eye into the vitreous. The differential diagnosis for sudden bilateral vision loss includes vitreous hemorrhage and a CNS lesion. It'd have to be at the optic chiasm to get both eyes, unless it was a huge lesion somewhere else. In addition, not listed on the slide, you can get a toxic optic neuropathy through methanol or ethylene glycol, which will give you sudden bilateral blindness. That should also be looked for in the history. Vitreous hemorrhage. The etiology is often due to diabetes. It's usually long-standing and poorly controlled diabetics with neovascularization or proliferative diabetic retinopathy. What that means is they've had diabetes for so long, their retina has started to develop new vessels which are leaky and often bleed into the vitreous. You can also get vitreous hemorrhages from trauma or hypertension or wet macular degeneration, or if you have a blood dyscrasia and have a tendency for bleeding, you can get vitreous hemorrhages that way. Like we talked about, diabetes causes localized ischemia and necrosis of the retinal tissue. This leads to an increase in ischemic factors and VEGF, which is vascular endothelial growth factor, which produces leaky new vessels which bleed into the vitreous. The clinical pathology is red blood cells inside the vitreous or posterior segment. The signs and symptoms are blood suspended within the vitreous and poor vision. The basic diagnosis is based on the exam. You should get an ultrasound if you can't see if the retina is attached or not. Treatment often involves observation, waiting for the blood to clear out of the vitreous. Also, laser treatment of the retina will kill the ischemic retina and turn off the signal for VEGF, decreasing the need for neovascularization. Here are some pictures of vitreous hemorrhages. This in the top left, it's too dense to allow any view of the retina, and you can't do anything but wait for it to clear. On the bottom left and right, they show more localized hemorrhages. You can treat the visible retina with laser to turn off the VEGF signal. Case presentation number 7. A 49-year-old smoker presents with sudden onset of distorted vision in the left eye. So if we look through here, you see two pictures of a building. One has central distortion, and the other has a blind spot right in the middle. Macular degeneration is going to be the most common cause of distorted central vision in the elderly. It's due to age-related changes in the central retina, and you have risk factors for it, including smoking, not getting enough antioxidants. The pathogenesis is that new vessels grow into the subretinal space. This is different from diabetic retinopathy, where they form into the retina and into the vitreous. These are vessels coming underneath the retina. They leak fluid and they cause distortion of the overlying retina, giving you distorted vision centrally. This picture up here on the top right is supposed to show a new vessel coming through the choroid underneath the retina and causing distortion of the shape and therefore the signal interpreted by the retina. We often get subretinal neovascularization when you look histologically. The signs are changes in central vision, which is called metamorphopsia, where you have distorted shapes, decreased vision, and you can get neovascularization that you see on exam or with imaging testing. The diagnosis is based on your exam or imaging to detect the neovascularization. Treatment is not very good. There's lots of different ideas and lots of new things that are coming out. You can try laser, steroids, or other types of therapies. None of them work particularly stunningly, but there's lots of different areas and you won't be asked to determine which one to use. Macular degeneration clinically looks like these pictures. The top left, you can see early changes in the macula, but if you look closely, there are some scattered pinpoint areas of lighter speckled things. These are accumulations of material underneath the retina, which will lead to the neovascularization. They're more dramatic in the bottom left and bottom right pictures. You have new exudates in the bottom left, which lead to those white creamy spots, which are exudates. And at the bottom left and the bottom right, you see red spots, which is new blood, showing new neovascularization underneath the retina, which would cause blind spots and distortion of that vision. Case presentation number 8. A 45-year-old man with Marfan syndrome presents with 3 days of flashes, floaters, and now a curtain coming over the vision in his right eye. This is something most physicians should be aware of. It doesn't happen terribly frequently, but if you have somebody talk about flashes, floaters, and a curtain coming over their eye, you should be suspicious of a retinal detachment. This picture shows clinically what a retinal detachment looks like. Superiorly, you have abnormal white, billowing retina as it waves in the breeze in the vitreous of the posterior segment. Inferiorly, you have normal attached retina the way it's supposed to look. The differential diagnosis for a curtain coming down over your vision also includes amaurosis fugax, which is important and you don't want to miss it. It's a precursor for TIAs or strokes, and so you should do your normal stroke workup in somebody who you don't diagnose a retinal detachment in. Retinal detachments, you might want to ask about a family history of retinal detachment or a history of trauma, prior eye surgery, or flashes and floaters prior to the onset. Amaurosis fugax will not present with flashes and floaters prior to the sudden decrease of vision or the shade coming down. The etiology of retinal detachments are usually due to trauma or previous ocular surgery. Also, sometimes with people who are extremely myopic or nearsighted, they have longer eyeballs, which stretches the retina in the back and causes it to be predisposed to tears and detachments. Also, age, family history, and Marfan syndrome are also risk factors for retinal detachment. The pathogenesis is that all of these risk factors together create tension on the retina, causing flashes and floaters. As the retina is disturbed, the only thing it can do is transmit light signals to the brain, which are seen as flashes. The floaters are a subsequent development of red blood cells in the vitreous. A hole develops in the retina, and fluid can seep in behind the hole and cause detachment of the retina from the retinal pigment epithelium. Clinical pathology, you have neurosensory retina separated from the underlying photoreceptors, or RPE, which is the retinal pigment epithelium. Signs and symptoms are flashes and floaters or visual field defects. You also can get blood in the vitreous from the broken vessels as the retina detach. Basic diagnosis is based on exam and imaging if you need to. Treatment is surgical repair. It often needs to be done quickly, rapidly, in order to restore any functional vision. This is a picture that shows the floating, detached retinal layers. You can see on the bottom the scalloped layers of photoreceptors that normally would be attached to the RPE. Case presentation number 9. A 68-year-old with multiple myeloma presents with sudden, painless, total vision loss in his left eye starting 2 hours ago. This is a concerning case, and we'll need to look at it. The differential diagnosis for sudden, painless vision loss includes the vitreous hemorrhage as we talked about, which can happen in one or both eyes. Also, for monocular, sudden painless vision loss, you need to think about a retinal vein occlusion or a central retinal artery occlusion. Also, strokes can cause sudden painless vision loss. Since we've talked about strokes and vitreous hemorrhages, we're going to talk about vein occlusions and artery occlusions. The etiology for a central retinal artery occlusion is embolic phenomena, which causes emboli to lodge into the terminal vessels of the central retinal artery. These can come from thrombotic plaques in the carotid arteries, or they can come from emboli dislodged from the heart valves as they go through the systemic system. Central retinal vein occlusions are often due to hypercoagulable states, or diabetes, or atherosclerosis also. The pathogenesis is occlusion of the central retinal artery or vein. Both of them lead to ischemia of the retinal tissue. Here's some photos of vascular occlusions. On the left, you have a central retinal artery occlusion with a white, infarcted retina throughout the entire distribution of the central retinal artery. There is, however, a cherry red spot in the macula, which indicates the dual supply for the choroidal vessels into the macula. On the right, we see 2 pictures of central retinal vein occlusions. These have a markedly different appearance. They're called the blood and thunder retina because you have diffuse retinal hemorrhages and edema. You can see how there's a big difference between these two, and just looking at the retina fundoscopically will help distinguish between these two identities. The clinical pathology of vascular occlusions are atrophy and tissue necrosis of the neurosensory retina. Signs and symptoms, like we talked about, are sudden painless visual loss. You'll get a cherry red spot in central retinal artery occlusion, and you'll get a blood and thunder retina and a vein occlusion. The basic diagnosis is the exam, which will help you know what it is, and then your ancillary workup. You need to find what the cause is. You'll look for a Holland-Horst plaque on a central retinal artery occlusion to identify embolic phenomena. You'll do the heart valves, you look at the carotids. For a vein occlusion, you can do a hypercoagulable workup. Treatment is often supportive. By the time the retina is ischemic and infarcted, there's nothing you can do about it. So supportive measures usually are the only thing we can do. Often heroic measures are employed, but they're usually not very successful. The next section is the optic nerve, and we have a case presentation to start it out. A 34-year-old woman with a past history of transient hemiplegia presents with decreased vision in the left eye and pain with eye movements. When we look in the back of her eye, we see this optic nerve appearance, which is different. It looks swollen. The borders of the nerve are indistinct and they're fuzzy, and the nerve looks elevated. Your exam shows a normal-looking eye on the outside, markedly blurry vision in the left eye, and unequal pupillary responses. The differential diagnosis includes optic neuritis, which is inflammation of the optic nerve, or iridocyclitis, which is a type of uveitis. The etiology of optic neuritis includes young women. Often they have a history of multiple sclerosis, or they may subsequently develop multiple sclerosis. Pathogenesis is that it's demyelinating inflammation, and it happens specifically at the optic nerve head. Inflammation causes changes, which are mostly reversible, in their vision. The clinical pathology is inflammation of the optic nerve leading to visual defects. Signs and symptoms, like we talked about, are a swollen optic nerve or optic nerve edema, often in one eye rather than the other. You can get a Marcus gun pupil in the affected eye, which means you have a relative afferent pupillary defect. As you shine the light from the unaffected eye into the unaffected eye, both pupils will constrict. As you swing the flashlight over to the affected eye, both the pupils will dilate, which means that the retina and the optic nerve are not working correctly, and that's due to the disease process that's going on in the optic nerve. The basic diagnosis is a physical exam. It's often recommended to get an MRI to look for multiple sclerosis. The treatment is often observation, although sometimes you can advocate for high-dose steroids to stop the inflammation. Optic neuritis histologically looks like this. On the top we have a normal-looking slide, which you should recall from the previous description of the optic nerve. Optic neuritis looks like this lower picture. That's a Vesuvius optic nerve. It's exploding with inflammation and swelling. It looks markedly abnormal from the one above it. Lastly, we'll talk about the eyelid, and this is case presentation number 11. You have an 82-year-old farmer who presents with a lesion on his right lower lid. It's been there for ages, decades, and it's recently ulcerated and started bleeding. Here's a picture. You look at that lower lid, you know it's not normal. The first thing that should come into your mind is cancer. The etiology of basal cell carcinoma, or skin cancer of the eyelids, is sunlight or toxic exposure. The morphology is the picture of basal cell carcinoma like we saw in the previous slide. Basal cell carcinoma is by far the most common skin cancer of the eyelids. The pathogenesis is UV-induced changes in the cellular tumor suppressor mechanisms. Clinical pathology is you get palisading epithelioid cells. Signs and symptoms are sometimes tearing from the irregular tear margin or from irritation of the tear drainage systems. You can often get a large eyelid mass that screams, "I have cancer." The basic diagnosis is the physical exam. It's often confirmed by biopsy. Treatment is always surgical excision. Usually we employ the dermatologist to help us out with Mohs surgery. That's the end of our ocular pathology slides. I hope you enjoyed it. I believe the material is high yield and will help you as you take your USMLE exams. Good luck.